This week on the Back Table Podcast.
I think this conversation just goes back to the whole purpose of this particular section is the importance of an MDT. The more you know, the more you don't know, right? And so when you reach that point of like, there's only so much we know, we're at a point where we really don't know. That's when I think the benefit of having a multidisciplinary tumor board really shines, where you really get kind of informed input from different perspectives that really help you try to get to a reasonable option in a very complicated situation.
Welcome to Back Table. My name's Scott Genshaft, and today we'll be having a conversation about multidisciplinary management of lung cancer. We have a panel today, but let's start out by introducing each of ourselves. Karen, would you like to introduce yourself?
Hi, I'm Karen Reckamp. I'm the Division Director of Medical Oncology and Thoracic Oncologist at Cedars-Sinai in Los Angeles.
Hello, everyone. My name is Scott O. I'm an interventional pulmonologist at USC in Los Angeles.
I'm Scott Attai. I am a general thoracic surgeon at USC in Los Angeles.
I'm Alan Lee. I'm a radiation oncologist at UCLA, specializing in brachytherapy and thoracic oncology.
Okay. Well, I think that one thing we should start off with is discussing tumor boards and how it's organized at our institutions and what we've seen that is effective and ineffective in managing a tumor board. So, Scott, could you explain how tumor boards run at USC?
At SC, our tumor boards really, again, focus on a multidisciplinary effort. So we have all specialties really represented who have anything to do with thoracic oncology, including specialties like pulmonary, pathology, radiology, rad-onc, et cetera. Surgeons as well, of course. We really will have cases brought by any specialty. They will get presented by the provider who had been taking care of the patient. And then each specialty essentially will run through a component of that case that is relevant to them. So our radiologist will review the imaging. Our pathologist will discuss the pathologic findings, and then we'll talk about treatment options, whether that be surgical, medical, interventional, or otherwise, and then try and formulate a plan for that individual patient that we all feel is going to be best practice and also best treatment plan for their case specifically.
Karen, is something similar at Cedars?
It's a similar process, and I think that one of the benefits in the post-COVID era, we have gone to virtual or hybrid tumor boards, and so we do have some people in the room, but we also have the ability to join online, and so even our community sites and other people who might not be available in person are able to join that tumor board. So I think that's been a game changer for us to make sure that we're doing continuity of care across all of the sites, and we allow more of our treating physicians to engage in the process.
Yeah, I think with these expanding healthcare networks, certainly we have the same situation at UCLA. This has really expanded our ability to meet the needs of our community-based patients. I'm wondering, Scott O., do you think that there's anything that's been lost in these web-based or Zoom-based meetings for tumor board?
For sure. I mean, we all talk about the chats that happen over the water cooler historically, right? So the chats before the conference starts, after the conference ends, about potential projects, potential other patients, last minute add-ons, things of that nature. I think we miss a little bit of that. And also the kind of personal connections you make with your colleagues in person, which allow you to, I think, be more comfortable with each other to some degree, so that if you're in the middle of a case and you're like, hey, I'd like to get Karen's input on this case on whether or not how really important it is to biopsy this lymph node, or do we need to really biopsy both nodules, or should I drop a fiducial in this nodule in the middle of the case? And being able to have that really close relationships with your colleagues that are super comfortable, that let you reach out, very easily. And I think it's harder to get to that point when it's all virtual as new faculty members or group physicians join the group. And I think that's kind of, I missed that a little bit. So I think, that combination of meeting sometimes in person and sometimes virtually might help correct some of that.
And Alan, how's this been managed at your institution at UCLA?
Yeah, I think really similarly. We also have all these different specialties come in and review the cases. We talk about it pretty collaboratively. I was actually going to ask the group, when you guys have challenges in management of a patient or disagreements, I think what Scott O was saying is that when you do have those disagreements, if you do have them, being face-to-face with somebody, I think allows you to sort of, dissipate any tension and then be able to read the person's emotions and be able to sort of, come to an agreement in the best care for the patient, which I think is, what we're all there for, right? Do you guys have any different strategies for handling, disagreements or difficulties in challenging patients?
Well, that's a very good question. There may be some break time here, but I personally find that it's very difficult to dissipate that negative energy that can build up when it's not an in-person meeting. I think that there's a little bit more tendency in some tumor boards that I attend, not necessarily the thoracic tumor board, to have certain individuals kind of suck the air out of the room and drive all the discussion. And that really leads to less collaboration. So all efforts, I think your question, to your point, is very important. I'm interested in what everybody else has to say, because tumor boards are only valuable, in my opinion, and only enjoyable to attend if it feels collaborative. So I'm wondering, Karen, what do you think about this issue?
Yeah, I think it's a challenge. And I think on the virtual piece of it, there's often a lot of silence and uncomfortable silence when there's disagreement and trying to get through that. We do have one of our pulmonologists who is not afraid to say, well, I was thinking maybe this, and then kind of breaks into that kind of tension to make people start talking again. And so I think we have some personalities that help to move it along, but it is a challenge. It's a challenge in person too sometimes, but I think that's part of what the tumor board is trying to get at. And you're not always going to have a perfect answer, especially as lung cancer treatments become more complicated and more complex. There are more options to offer for patients, and that's why we're here to talk today.
Yeah, I think that it's interesting that you mentioned the role of the pulmonologist in the tumor board, because to a certain degree we have Scott here because he's a renowned interventional pulmonologist who's really been advancing the field of interventional pulmonology. But we also have general pulmonologists who attend. They're not necessarily involved in the management of the cancer itself, but they're definitely involved in the management of the patient. And I personally have found that pulmonologists serve a very important role in help navigating the conversation with regard to treatment options, particularly with regard to what a patient can actually tolerate. And this comes into play quite significantly, I think, for those of us that are treating lung cancers and really identifying if a patient's able to tolerate certain kinds of therapy. This might be a good time to talk a little bit about that. So in discussing early stage lung cancer, how are those cases brought to your tumor board, Scott? Are all cases brought? Are there only certain cases you like to bring or people bring?
That's a good question. I think to your point about the pulmonologist, I mean, along the pathway of disease treatment for lung cancer, it starts with diagnosis. And that's often where our pulmonary colleagues start it. They've identified it on a low-dose screening scan, or a patient's sent to them for some other complaint. They get imaging, they identify the disease. So they start there. They have a longer standing relationship often with the patient, and so they can sort of initiate that. Once it comes to what we presume to be an early stage lung cancer, maybe diagnosed, maybe in the process of it, we try as a group to bring every one of those cases. And the reason for that is twofold. One is there's more than one option, right? We have specialties here, all of who can treat early stage lung cancer. So we want everyone to get a bite of the apple, so to speak. The other piece of it is that now we know that early stage lung cancer isn't this homogeneous group. There's these high risk and these low risk. And so like most institutions, we have trials open that allow patients with early stage cancer to be evaluated, considered for more advanced therapy or less. And so I think making sure that you can have that discussion, do they fit a box for a trial? Should they be getting radiation? Should they be getting ablation? Can they tolerate those therapies? We want all of that there, even in your most straightforward cases.
So most patients that come to your tumor board, do they carry a diagnosis of cancer by the time they reach the tumor board, or are there some patients that it's still a diagnostic dilemma?
From my perspective, the nodules that get detected, at least in my practice, are largely incidentally detected nodules, not screen-detected nodules. I think largely because lung cancer screening uptake isn't great in the United States, right? I think the latest American Lung Association data for 2024, which is the latest available, the national uptake rate is about 16%. So only a fraction of people who are eligible for lung cancer get their scan. And even if the nodule is found, the risk of lung cancer of a screen-detected nodule is pretty low, less than 5%. So most of the nodules that come across our practices in interventional pulmonary, a lot of them are incidentally detected, or patients with known cancer are getting active surveillance. So we only bring those cases of undetected nodules to the tumor board if we think they're a potential candidate for directed treatment, or maybe not a candidate for treatment at all because their comorbidities are so bad. And only then do we say, all right, do we even need to do this biopsy? And when that question gets kind of brought up, then we bring it to the tumor board to say, hey, look, if no one thinks this patient's a candidate for treatment, why you do a diagnosis? Or if our pretest probability is so high and we're not going to believe the biopsy results, if other than cancer, might as well go straight to treatment. So if that question arises, then I think those come to tumor board without a histopathologic diagnosis. Most of the other ones that are intermediate risk, we end up biopsying and getting a firm histopathologic diagnosis and hopefully getting the staging done and the non-invasive staging done and before they're brought to tumor board.
I guess it varies by week to week, but I don't know, 10, 12 on an average week maybe seems about right.
Probably so, a little less maybe for us, maybe 8.
Well, ours is capped, supposed to be capped at 7. And then we go over time. Sometimes we only get through four of the cases. But we also have a lung nodule conference on Tuesdays, which is usually the cases are presented by pulmonologists. Some of them are interventionalists, some of them are not. And I think they usually present the cases because they're sort of in a diagnostic conundrum, right? Do we biopsy? Do we not biopsy? Do we just treat without a biopsy? So we have an additional screening, I guess, layer.
Yeah, I think it's a very interesting shift that's occurred in the past, 15 years with regard to a biopsy, a tissue diagnosis prior to surgery, because even in the National Lung Screening Trial, a huge proportion of the patients actually went directly to surgery for their tissue diagnosis. Karen, from your perspective as a medical oncologist, what do you think about tissue? I mean, clearly you care about tissue. In an early stage lung cancer, what are you looking to see on a needle biopsy?
So I think that this has evolved, as you noted, and with the treatment evolution of especially the use of now neoadjuvant and perioperative therapy, that tissue diagnosis, unless it's really, really early stage, which sometimes we don't know with just the imaging, I think doing a biopsy and often mediastinal staging to understand what we're dealing with and whether a patient might need to have some perioperative therapy, neoadjuvant therapy, again, especially with the use of immunotherapy in this setting.
Okay. And Scott, where are you at on getting a tissue diagnosis prior to taking a patient to surgery?
So it's interesting because I think it has shifted, and we still see it a lot where patients are sent to us, the surgeons, with a nodule without a diagnosis by often a community pulmonologist who will say, can you do a wedge or resect this to get a diagnosis? And then that's a case that I often will bring to the tumor board and say, Scott, can you get a diagnosis before I go diving into this chest? Because again, maybe there is an option for another treatment strategy for this person. A lot of the times we will push for diagnosis first. There is still a role for difficult to reach lesions, ones where we think, again, diagnostic uncertainty based on biopsy, where we'll just do it. We'll say we're going to have to just resect this. We believe it's early stage. There's nothing else. But even now with liquid biopsy becoming more sort of in vogue and we're using that more frequently, there's options to get these diagnoses. And as a surgeon, I can say I've resected presumed cancers that are not, and we have not resected presumed not benign lesions that are. And so I think we try and walk that fine line and make sure that we're achieving a diagnosis and a therapy without undue risk.
From a biopsy perspective, the thing that's changed most in my approach on who gets biopsied, who doesn't, I feel fewer and fewer people go straight to treatment. And I think for me, one of the most astounding papers that I've recently read is the 5-year survival for Checkmate 816. And those with complete pathologic response having, a 94% 5-year survival. And I was like, wow, when have we ever had a 95% survival in any lung cancer treatment trial of any stage, right? And that was just mind-blowing to me. So then I began to ask myself, what is the importance of biopsying and staging? And what is my pretest probability for an N1 lymph node have to be my threshold to do invasive staging before proceeding to a definitive treatment? because once you do the definitive treatment, you lose that window for neoadjuvant treatment. And we don't yet know if adjuvant is not inferior to neoadjuvant. So we don't have that data yet. So my threshold to do invasive mediastinal staging has just gotten lower and lower and lower because the importance of finding that radiographically negative N1 lymph node is becoming more and more important. So I would like to ask this group, what does your pretest probability for an N1 lymph node have to be to warrant invasive mediastinal staging? So is a 5% risk too low? Is that where the cutoff is, 10%? Like, at what point do you feel like, oh, we can go to treatment without invasive mediastinal staging?
So I appreciate your comments on the 5-year survival in the era of immunotherapy and chemoimmunotherapy is changing the way we're thinking about things. And I think there's a lot of evolution right now. And so I think there are two pieces to that. Number one, in my world, because I see the kind of the worst cases, right? I think 1%, like there's no percentage. If you're going to get a 95% cure rate and these lymph nodes are positive, if you have lymph nodes positive, it's, less than 50%. And so you're taking away that chance of cure for those patients. So I think that the answer should be almost everybody. And we've seen plenty of those small peripheral nodules that then have N1 or N2 lymph node disease at the time of surgery. So and again, I see those a lot because they end up in my clinic. But I think that the threshold has to be quite high to stage the mediastinum. The second piece is now we're getting more advanced ways to sample the mediastinum. Often we're getting smaller tissue samples with those mechanisms. And we really still need to be able to do genomic testing, PD-L1 testing on those samples. And so the amount of sample that we get needs to be robust enough. When we used to do tumor boards a decade ago, it was all about how can we stage this patient to get them to their cure if that's the possibility. And so now mediastinal staging and lymph node staging is going to be part of that early on.
Yeah, I mean, I think especially when we're thinking about the upstaging, right? From my side, every time that I have a nodule where I will ask Scott or his group to do a robotic bronch, can you do this? Is always like, well, you're there, can you do an EBUS? It's just sample it, right? There's no downside to it from my perspective. The other piece is from the surgical side is that we do upstage. It's just the reality of it. There are nodes that aren't reachable. I recently had a case where it was a, micrometastatic. It's a 1 millimeter deposit in a 1 centimeter node. The sampling error on a needle is going to be pretty high. So they upstage. So the goal has to then become not having surgical morbidity that precludes them from achieving systemic therapy afterwards. Because the upstaging is unfortunate, but what's more unfortunate is if I do an operation and they struggle and they never get to the systemic. Now, in the immuno era, right, we don't know if giving immuno with tumor in place is superior to giving immuno after resection when we have no evidence of disease on imaging, but presumed that there's something still there. So maybe we still are losing that impact by resecting them before they get that therapy, but at the very least, we have to get them to it. And so if we operate on someone who I suspect is not going to do well or struggle afterwards and has a high risk of upstaging, that's a patient who we have to know beforehand. Otherwise, they're never going to get their systemic therapy.
Yeah, I actually had a question in response to your question, which would be, does the operator's skill doing the EBUS change your recommendation for threshold of EBUS? Meaning, for example, if I can get an EBUS done very quickly, which I can at UCLA, mostly because you set the program up there, but very easily, and they're quick and they're trained there a lot of the time, that I trust that it's going to be done effectively. But there are many times that I'll get EBUS from outside, and occasionally it'll be, no sampling of lymph nodes and things like that. So I wonder, and I want to know your opinion about that sort of pre-test probability of appropriate sampling based on the operator doing the EBUS.
Thanks for putting me on the spot, Alan. No, but I think we all know this.
Yeah,
right?
yeah.
Like we all know, we as physicians, I feel like one of the most important things we need to know is when to refer, right? So if you're a general radiation oncologist and you do everything, when do you need to refer to a thoracic radiation oncologist? When you're a general IR and you've got a high-risk challenging case, when do you refer to the thoracic IR group? We all make this clinical decisions all the time, right? So I think every physician out there needs to make that clinical decision for themselves. And at the end, we should all be driven by what's best patient care. If you've got a 3-centimeter M3 lymph node that you can hit with your eyes closed, like anyone can do that, right? And that's going to be easy to do. If it's a marginal patient that you're thinking about, well, maybe this is a candidate for 2-for-1 lung volume reduction surgery and lobectomy because there's such bad emphysema, man, we better stage this patient really, really well. It's a middle of the lung, 1.7 centimeters, spiculated nodule. Where's the real edge of that nodule? What are the chances of a radiographically occult mediastinal disease in that patient? Boy, we better do a really thorough linear EBA staging that's going to essentially replace and be comparable to mediastinoscopy. Like, you better think about, am I the right person to do that case, or do I need to refer that patient, right? So I think as physicians, we need to make that judgment call ourselves for each one of our patients, right? And we're in Los Angeles. You turn around and there's a thoracic medical oncologist or a thoracic surgeon or some specialist of any disease around every corner in Los Angeles. So that should never happen in LA. I can imagine in more rural areas where a patient may have to drive 5 hours to get to a medical center with you do the best you can for your patients, right? And that's what you have to, I think, make that call for yourself as a physician all day, every day for every patient.
Yeah, that's why tumor boards are really important, right? Because we all talk about it. Sometimes we'll send patients for a second EBUS, or maybe they need invasive mediastinal surgical staging, right? And the conversations that we have during tumor boards are, just for the patient's benefit, right? That's all I was trying to ask you about, but yeah.
I feel like one of the most important things we need to know is when to refer, right? So if you're a general radiation oncologist and you do everything, when do you need to refer to a thoracic radiation oncologist? When you're a general IR and you've got a high-risk challenging case, when do you refer to the thoracic IR group? We all make this clinical decisions all the time, right? So I think every physician out there needs to make that clinical decision for themselves. And at the end, we should all be driven by what's best patient care. If you've got a 3-centimeter M3 lymph node that you can hit with your eyes closed, like anyone can do that, right? And that's going to be easy to do. If it's a marginal patient that you're thinking about, well, maybe this is a candidate for 2-for-1 lung volume reduction surgery and lobectomy because there's such bad emphysema, man, we better stage this patient really, really well. It's a middle of the lung, 1.7 centimeters, spiculated nodule. Where's the real edge of that nodule? What are the chances of a radiographically occult mediastinal disease in that patient? Boy, we better do a really thorough linear EBA staging that's going to essentially replace and be comparable to mediastinoscopy. Like, you better think about, am I the right person to do that case, or do I need to refer that patient, right?
So are patients making it to mediastinal surgical staging with you preoperative?
So preoperative mediastinoscopy, I would say, at least in our institution, is a rarity. I mean, the quality of the EBUS is high enough, and it only really falls in the role of it, at least for my practice, is if I have a extraordinarily high suspicion based on, metabolic imaging and an EBUS that is negative, and I just, maybe the EBUS sampling didn't have lymphatic tissue in all the stations, maybe I just did not feel confident in it, operator dependent or otherwise, or for outside, or for whatever reason, maybe Scott said, it was really tough, just like we were getting it, but there was a lot of blood elements, we weren't getting a good sample, then I'll reserve that. But it's a rarity. I mean, I probably am doing like one every other year, honestly, because EBUS is just such a high quality procedure at this point.
And when did that change happen?
I mean, honestly, when I started at SC was going on about 9 years ago. And at that point, we were doing a handful a year. In fact, actually, most of the ones we were doing were through the DHS system where we didn't have the exposure to EBUS. Probably, over the last, 5, 6, 7 years, we've really just gotten rid of it. I mean, even when I was a fellow in training, it was extraordinarily rare. I mean, I did a couple of them as a general surgery read. This is like, 2010. Then we were doing them more routinely, but over the last 5 or 10 years, we just have abandoned it almost.
So I'd like to take a step back to lung cancer screening. So you mentioned the poor uptake in lung cancer screening. What does this due to?
That's a loaded question. There's so many factors. There are patient factors. There are healthcare system factors. There are primary care provider factors, specialty factors, access to imaging, and reimbursement. So all those things have been studied and reported on. I say this a little bit, it's a terrible thing to say, but it's to get a point across. And part of it is to try to get rid of the stigma of lung cancer. I think a lot of patients who get lung cancer, it's my fault, it's your fault, you smoked, it's your fault, like you did it to yourself kind of thing. But even in the US, about 1 in 5 lung cancers are not smoking related. In the Asian American women population, about half of lung cancers are not smoking related. And in certain parts of the world, it's predominantly not smoking related. So there are lots of factors. And I think part of it is we have to stop calling it lung cancer screening. And I think we should adopt what the UK and the NHS have done, which have done a phenomenal job. They call it a lung health check. It's not lung cancer screening, it's a lung health check. You come in, you just like you get your physical, you get your lung health check, and if you qualify. And I think that along with kind of a systematic institutional support on a public health level, really pushing for it. I think in certain areas of healthcare systems in the NHS, lung cancer screening uptake is about 70%. And they're close to reaching a point where they've at least offered lung cancer screening to 100% of their eligible patients that is in their encatchment area. And we're not anywhere close to that in the United States. The stigma needs to go away, right? Do you have coronary artery disease? Well, what did you have for lunch yesterday? Is it what you ate and you did it yourself? We don't have any of that for most other diseases, but there's such stigma associated with this. And there's also like the patient nihilism, like a lung cancer death sentence.
I think that's a big piece because I hear that from patients where, even just talking about therapies, like in the US, obviously the majority of lung cancers are diagnosed at an advanced stage, right? Regionally or distantly advanced. And so everybody's got a story about their grandmother who got chemo and it killed her, or got radiation and she did terrible. And so they already have sort of resigned themselves to like, what's the point? Because if you find it, this is the treatment, it's going to be awful. And I think that really drives that decision-making for the patients, whereas, just socially and what we see, screening for colon, screening for breast, screening for prostate, these are all things where you see a face on a media campaign, you see a survivor, you see people who are thriving, and that is not seen it's not as visible for lung cancer. The visibility is, well, my grandfather had it and they did terrible. So I think people just don't want to know. They'd rather kind of go, is it an ostrich or an emu? Bury your head in the sand, I guess, whichever great bird it is.
I think one of the issues that's come up with lung cancer screening that we realized right away, and it's a good thing, is that we're picking up ultra small, ultra early nodules, which we were never finding beforehand, maybe occasionally incidentally. I think that this has caused a major dilemma in how those are managed. Whether we observe the nodules, whether we go to a biopsy, how we do the biopsy, how we actually do definitive therapy. What are your thoughts, Scott, as a pulmonologist on this phenomenon?
Yeah, I don't know how many times over the practices, and this is standard of care, is like we'd watch a small nodule grow before we do anything. And I think one thing I never really appreciated before current available techniques is that there's a survival difference between stage 1A1 and 1A2 and 1A3. So a 1 centimeter versus a 2 versus a 3 centimeter isolated nodule, there's a significant 5-year survival difference. If you look at I think the latest data that I saw is from 2017 that was published, where they break it down. I'm sure the latest ISLC 9th edition, I haven't done a deep dive into that, but there's almost a 9% 5-year survival difference between 1A1 and 1A2. So if you wait for that nodule to grow from 8 millimeters to 12 millimeters, you just jump that stage from 1A1 to 1A2. So with that in mind, I'm like, wow, an absolute increase in mortality of almost 10%. It's important to diagnose and stage people get them treated as quickly as possible, as early as possible. So I think now for me, it's not a matter of size of nodule. It's a matter of what's my pretest probability of cancer? And if this is cancer, am I going to treat it? And if so, we should try to get an answer for this patient and get them treated as soon as possible. There's been 2 abstracts published for bronchoscopic biopsies of subcentimeter nodules. And in both studies, the incidence of cancer in subcentimeter nodules was 50% or higher. And these are small case series, right? It's a single center, one's multi-center, one single center. But subcentimeter nodules, having a malignancy risk of greater than 50%, some are primary lung, some are metastatic. But we used to never think about biopsying subcentimeter nodules, right? It was just kind of like 1 centimeter around that time was the threshold for PET positivity. The threshold to do a biopsy was kind of that somewhat arbitrary 1 centimeter mark. But whatever people are using to decide, well, I better biopsy this subcentimeter nodule, clinicians are making the right decision, I think, when over 50% end up being cancer, right? So I think that's something that has changed in our approach, that we now think, even if it's subcentimeter, if the risk is high enough, we need to get this diagnosed and treated as soon as possible.
I think one of the challenges is understanding the pretest probability when now we have programs that are generative AI that are doing the first read on the pulmonary nodules and I think this is pretty widespread now that these programs are being used and they're being read by radiologists after, but these may have been nodules the radiologist couldn't perceive. So I don't know that we know the pretest probability of what cancer is in these subcentimeter nodules that are now being identified by generative AI. And again, hopefully it will learn from itself and we'll start to get that information. But I think we're in a new frontier now, and we may be getting some more, lead time bias and some nodules that may never decrease a person's lifespan at all.
Right.
And we may start going after these.
That's the question, right? What is a clinical, people hear lung cancer and they assume it's one big box, but what is a clinically significant lung malignancy? Because there's definitely, I think we probably all have had patients with a ground glass lesion. If you biopsied it, it's going to say lipidic type adeno. And they're 84 and it doesn't matter. They're going to live another decade with this very slowly progressive ground glass nodule. Doesn't matter if we treat it. Do we even need to know what it is? And how do you convince the patient, not convince, but how do you explain to a patient that you might have lung cancer, but we're not going to do anything about it? Because, again, for the therapy I can offer, I can take it out and say, great, you're cancer free. But my operation comes with a real non-zero risk of major morbidity. Is it worth exposing them to that risk for something that may never clinically matter?
It's a good problem to have, right? Who would have thought that would be like 10 years ago that, oh, it's lung cancer, let's leave it alone. Like that wouldn't have even crossed my mind. But now we're getting to the point where we're talking about lead time bias, over diagnosis biases, over treatment biases. And I think it's a great position to be in. And we know a lot of the kind of objective metrics or score, risk stratification score, like the Herder score, et cetera, they don't perform well for subcentimeter nodules because they weren't developed with those nodules in place. So I think the currently available validated objective risk stratifications scoring systems are not really relevant to those small nodules. And again, it doesn't tell you if this nodule is going to be a life-limiting process or not. And like you say, maybe these AI machine learn algorithms that help risk not only detect nodules, but give you some insight about potential tumor biology of these and trying to predict which ones are going to be life-limiting and which ones are not will be super important in helping us risk stratify the right patients to diagnose and treat and the right patients to just leave alone because we know it's not going to be a problem.
Yeah, I'm really hopeful that, I don't know if it will happen in the United States, but maybe in some other countries who are a little more cost conscious, that there will be these observational studies. I will say from my perspective as an interventional radiologist, the discovery of these very suspicious subcentimeter nodules has led to a number of outcomes. One would be we are just performing percutaneous biopsies successfully on very small nodules at this point. It is horrible. We are doing so many lung biopsies, we can't get on top of them. But our yield is north of 90%. So we're giving you the data, the clinicians, the data that we need. The question then has arisen is how do we manage this? So when we were treating patients with lung cancer with ablation early on, our patients were largely older, with terrible comorbidities, not surgical candidates, not candidates for radiation. And those were the patients that we were treating. And our outcomes were understandably not as good as a patient with less comorbidities. Now, in the era of lung cancer screening, this is the ability to ablate and perform a local treatment as an outpatient basis has, I think, given an option to clinicians to maybe, quote unquote, zap a lesion that Scott's not super keen to take to the OR, because you're probably right. That patient's probably not going to die of that lung cancer. And I think that this is like an interesting question that a tumor board needs to discuss. Do we observe patients? And if we don't, how should somebody that you think is not going to die of lung cancer and you think is not going to die of lung cancer, but you find it difficult to tell them you have lung cancer, but we're going to watch it, how should we be managing that patient?
Yeah, so I think I usually work backwards. So I talk to the patient, right? And it's actually funny because it's very hard to convince someone once you tell them they have cancer that they shouldn't get treatment or they don't need treatment, right? And I treat prostate cancers also, and that's a very common problem we have then also. It's a good problem to have, I guess. So the patients will say, I really, really want treatment. What are the risks of your treatment, right? As a radiation oncologist. And when I give them the numbers, they're like, so the risk is extremely low of anything bad happening to me. So then can I just get the treatment then? And, presenting at the tumor board and so on and so forth, I end up just treating a lot of these patients because, quite frankly, 99% of my patients will not have a significant long-term morbidities or side effect from the treatment. Yeah.
I think that's where the sort of step past the tumor board, at least for us, is a tumor board happens, we may talk about a patient, and then they land in our multidisciplinary clinic. And that's where they get the opportunity to then kind of hear what we talked about together. Is they will, again, for these early ones, they're going to see radiation oncology, they're going to see me, they're going to see medical oncology, they may see somebody from IR and say, well, here are what we think is a good idea. But hear from the radiation oncologist. They're going to tell you what their therapy looks like. They're going to tell you what to expect and what the outcomes are. And I'm going to tell you what mine are. And then you get that shared decision making. We're going to present these options to the patient. And I think that gives them a better opportunity. And again, it's just an extension of that tumor board into the clinic with the patient.
And also for surgery versus radiation, which is like the biggest question most of the time. There are trials looking at that right now. They're going to publish for a little while. But oftentimes the conversation is just that, so surgery came first. It's the gold standard. You should get surgery if you're healthy enough and you're young enough and the surgeon thinks you're a great candidate. I think that's perfectly fine to say. The intralobar failure with radiation versus a lobectomy is obviously higher, right? Because there's still a lobe there. Maybe the regional recurrence is higher because we're not doing a lymph node dissection at the time of our radiation. We don't treat electively the nodes. So there's definitely advantage of the surgery versus radiation. So it's just a conversation both with the surgeon, who hopefully is collaborative, and then with the patient, who can understand their own risks and make their own informed decision.
Do you think about that a little bit differently when you're talking about a potential wedge resection or sublobar resection in general?
To a certain degree, I guess the general conversation that, usually the end of every conversation, I guess I'll start at the end with the patients is, if you get surgery and there's an issue, you have a local failure after a sublobar, maybe staple line failure, you can get radiated. If you get radiated and you have an in-field recurrence, I can resect you later. So you aren't burning a bridge in either direction. So you get to make a choice. Again, realistically, the difference between a lobectomy and a sublobar resection, when we look at like really big studies, the pulmonary function is better-ish, but it may not be, again, clinically that meaningful. The outcomes are pretty close. We still offer sublobar the bulk of the time now for these early stage lesions. But the advantage that I tell patients is we'll take out the nodes and we'll stage them. And most of the time, again, that upstage rate for a fully staged patient is going to be exceedingly low. So we're probably not gaining a huge advantage. And then we can make a decision together about what to do.
I wanted to also bring up the issue in tumor boards of our patients that have either recurrence or even metastatic disease in my world, and have new nodules or new findings that then we need to discuss as a group, because fortunately, our systemic therapies are getting better and better. And so we need to use the tumor board to think about how to potentially do local therapies, even in our metastatic patients.
Yeah, what do you think? There's a lot of emerging data in this space with both radiation, with ablation, and kind of delaying change in systemic therapy. What are your thoughts on that in this era?
So I think there are bigger trials that are being done. Some of the early trials clearly were improving progression-free survival. The overall survival piece hasn't necessarily borne out. These are still very highly selected patients, even when they're on a clinical trial. And most of the trials are not doing completely standardized things for every single patient. It's kind of hard to do because the therapies are different. They may be on different targeted therapies, immunotherapy, all of the above. And then they may have brain metastases, they may have liver, they may have lung. And so there's so much variable information that these patients have at the start that I'm not sure what to make of the overall survival data. But it does improve progression-free survival. And our patients are living longer, even with metastatic disease, years now often. And living longer is important, even if it's not an overall survival or having longer time until you progress. And often these patients are on targeted therapy or immunotherapy with limited toxicity. And if they go to the next therapies, they're usually more toxic than what I had before. And so I think there's a big benefit. We have a patient right now who's on a EGFR inhibitor, and she's always had left-sided lung disease totally controlled. And last week, she presented with a new nodule in the right lung, which appears to be the same cancer. And it is the only thing that lights up on PET scan. So maybe with that case, all of you can speak to, but I think this is a treatment that could be done by any of you.
Do you think that something like that should be biopsied? Is that important to get some data on a nodule like that for you?
For me, it is partially because I knew she had the left-sided lung cancer and because she's never had mediastinal or lymph node involvement. So my thought, and she's had this cancer for years, that this could either be the same or it could be new. We did biopsy and it's the same. But and then for our help, we get the NGS and we can sometimes determine if there are other therapies that are helpful. But for her, I think local therapy is the most important.
And I think I know the answer, but Scott, is this something you would ever consider taking surgery?
So short answer is yes. Longer answer is, but maybe. I think this is a great opportunity where surgeons, I'm speaking to myself, have to accept the limitations of your therapy, which is the paradox of providing a local therapy for a systemic disease that doesn't align, right? So if we were discussing this in our tumor board, the big question would be, if I resect this lesion, will this patient's quality of life be impacted in a negative manner, knowing that they are at high risk of additional distant progression? So if we are putting them at risk and we don't believe that we're going to achieve this longer term outcome, then consolidate them with a lower risk therapy. If they're 5, 6, 8 years out and this pops up and you say, well, look, maybe we will achieve a good long-term outcome. Let's give them the we'll say the best option for definitive local control, then we'll resect them. But if it's a year out from their last progression, you know what? Probably my option is going to be a higher risk. Better to land with an ablative therapy, whether it's radiation or interventionally, to give them the good quality of life. Don't impact that negatively because you're still going to get good control of that disease locally.
Alan, is this somebody that you would want to treat?
Absolutely. I think that, so earlier on in our discussions, it was always sort of the easier cases we were discussing, right? Like the early stage. I think the harder cases are the ones that are totally off the beaten path, right? They've had 2 systemic therapies and they have an isolated recurrence somewhere that's easily treatable. What do we do for these patients? What is the best thing for the patient? The surgeon says they can operate. I say I can do radiation. The interventional radiologist says they can ablate. Do we need more tissue? If we do need more tissue, how do we get it, right? So these are the questions that come up that make it a lot more difficult and challenging to get through a bunch of cases in a day. But yeah, the short answer is I would offer radiation to this patient, tell them the risks and benefits, and then if the tumor board agrees, I would go ahead with treatment.
Yeah, from our side in interventional radiology, we do tons of lung ablation. We've been treating patients like this with oligoprogression for many years. We didn't have the supportive data to support actually treating these patients. I think it's fantastic that there's emerging data on progression-free survival for these patients. One of the great things about performing an ablation is you're already in there, so you can perform a core biopsy at the same time. And so I see a lot of times in our tumor board a case of oligoprogression, and there's a decision, after a decision's been made, we're going to do some local therapy, veering a little bit more toward ablation and getting a tissue diagnosis at the same time. Actually, I see these patients as optimal candidates for thermal ablation, because one of the great things about thermal ablation is there's very low impact on the remaining lung. Across basically all studies, there's never been demonstration of sustainable decline in lung function. We do expect that most likely this patient will develop disease in the lung at some point. And so leaving the door open to other therapies down the line, radiation, possibly even a palliative surgery, more chemo that could have, or systemic therapy that could have lung toxicity, I think is really important for good quality of life and long-term outcomes.
Yeah. So for patients that have a high chance of developing yet another recurrence near the area of the isolated recurrence in the lung, I do send a lot of patients to IRs, as you know, for ablations, because you guys have all seen the images of a radiation, flying saucers sort of scar in the lung, right? You can't really surveil anything within 3 centimeters of that target. And if that's important, then the ablation zone is usually much smaller. And the ablations, and tell me if I'm wrong, but it also tends to resorb completely over time for the most part, right? Where there's just like a little dot there remaining. With radiation, you have a near permanent scar. And what's interesting also is that I find that if I give a higher dose with radiation, that there can be a late inflammatory fibrotic reaction even. So then when you do a PET scan 2 years after the radiation was done, there's a focal area of FDG in the target. And we do a biopsy sometimes multiple times and it's negative. So that also makes a diagnostic conundrum in the future potentially. So I think that's why having all these tools is so great for the patient.
Do you have any concerns in performing SBRT on patients who have had some degree of pneumonitis on checkpoint inhibitor in the past?
Yeah, so I think that it's probably additive and not necessarily synergistic. I think the more interesting question or finding that I've seen is that when patients are on a TKI, namely Tagrisso or osimertinib, I find anecdotally, and we do have some evidence suggesting that there is an increase in pneumonitis, both radiographically and potentially clinically. It's just that it's very hard to measure these things, right? Like how do you measure radiographic pneumonitis? It's hard to grade, right? It looks different in shape or size depending on the tumor, a lot of variables. And then another question is, if we believe that to be true, when do we stop the agent that we think is synergistic in causing toxicity? We give it 2 weeks or 1 week, or we just treat through it, because if you stop it, then their other sites might progress. So the questions become very complicated very quickly. And there is, a lot of research trying to look at it. But anecdotally, it seems to me that Tagrisso or osimertinib does cause a synergistic increase in pneumonitis when I give them SBRT.
So osimertinib is one of the most common TKIs to cause pneumonitis, even de novo. And then if you add immunotherapy, if you add radiation, all of those things can exacerbate it. It's still uncommon, but I know that there's more caution now when we give those patients radiation that we often will hold, but they may have brain metastases that are controlled and you really don't want to hold it very long. And so it is a challenge. But we see the pneumonitis with osimertinib just de novo too. So I don't want to make it that all TKIs are going to cause the same problem. And I do sometimes see that people just want to blanket, take everybody off their TKIs. And I think osimertinib is a very unique drug in its ability to cause pneumonitis.
Yeah, I think there's a lot of interest in targeting MET amplifications, right? I can't remember the name of the drug right now, but we don't find there's any increased pneumonitis when we look at the data for combination with that. And then I guess with targeted agents also, like immunotherapy, for instance, we do find that there's not much of a benefit if you combine radiation with immunotherapy concurrently. The jury's still kind of out if doing it before is beneficial. It does seem to have benefit when you do it after radiation. It's just that concurrently it seems to not work well. But a lot of the trials that are negative, we're looking at doing it concurrently. And so now there's a lot of, I guess, disinterest in doing immunotherapy with radiation, given the negative trials. But I wonder if it's just a sequencing problem, not necessarily the drug itself.
There's some thought that the radiation will decrease the lymphocytes and make it less active, but overall, we're not seeing, maybe not harm, but we're not seeing benefit when we're giving immunotherapy and radiation. So I think that's really falling out of favor over the last few years.
Yeah, a big question I do have, though, is so right now, one of the paradigms is chemoimmunotherapy prior to surgery, right? And a lot of those patients, they will get chemoimmunotherapy, And then the surgeon will say, well, I don't know if we can operate on this patient anymore, for whatever reason that might be. And then so they're like, okay, now let's do PACIFIC, which is chemo, radiotherapy, followed by immunotherapy, right? We don't have any data for that. And in fact, we do have some data that when you combine chemo, immunotherapy with radiation, that's not good. But my question is like, is it beneficial beforehand? And then you give just radiation, or maybe just give chemoradiation without immunotherapy. Potentially that'd be a benefit there. Yeah.
And those trials are being done.
Yeah.
But they'll read out in 5 years.
Yeah, right. But in practice, what do you guys do when you guys get to a point where the patient got immunotherapy? I mean, hopefully they were determined to be unresectable or resectable like they're supposed to beforehand. But let's say that didn't happen. And then you get into that point. What is the common practice that you guys see happening?
Yeah, I mean, I think, as you said, I mean, we try and avoid that. We try and be real careful with decision-making preoperatively. So our sort of general position on it is you can't downstage to resection, or at least that's what a lot of surgeons will say, or should say. You can't downstage to resection. If you believe you can do that, you're wrong. If it's not resectable today, it's not going to be resectable in 3 months. So you got to make that decision now. And if maybe and then with the immuno, you don't know are you progressing? Are you not? Is it this pseudo progression in some lymph nodes? So so sometimes that does come up. But yeah, we end up with I guess we're going to shift to the PACIFIC, and it doesn't, we don't know if that really helps, but I think the goal is to just really avoid having to put a patient in the position where you had a therapy that has a really good outcome long-term, but you applied it incorrectly, meaning you decided to apply that therapy as opposed to PACIFIC up front, which has, again, very, very good outcomes. So really the application of that right up front is what's important, I think.
I think for that patient population, in my mind, one of the big questions is, what is the added benefit of surgical resection if you have complete pathologic response after neoadjuvant therapy?
But we don't know. We will never know if they have a complete clearance.
That's right. Yeah.
So we had a patient who was furious about his surgery and with a
We have that. I mean, now I've learned over time that I actually have to have that discussion with them in advance. There is a chance that you will not have any tumor left. Be prepared for that. It does not mean you did not need surgery. We do a lot of, it's outside the scope of this, esophageal surgery with chemoradiation preoperatively. We saw that a lot. I mean, for squames, it's 40 or 50% path CR. So we started to learn, we need to preface this to patients so they understand that that doesn't mean you didn't need an operation. At least right now, it doesn't mean that. In 20 years, we might find out that you didn't. But right now, that's still what needs to be.
It's a good problem to have.
Yes,
right?
Absolutely. Yeah, you should be thrilled. You're a path CR.
So going to that question that Alan brought up of do we now shift over to PACIFIC, all depends on is there a way to find out if this patient had complete pathologic response or not? Because if they did, and now we know that you don't need consolidation or any sort of treatment after that, then obviously you shouldn't do PACIFIC. But we don't know how to determine that yet without actually doing the surgery.
But we know also there are about 20% of patients who will never go to surgery after neoadjuvant, and that's the challenge of how do we treat them. And I think our goal is to get them to radiation, what to do around that radiation, because again, they probably didn't respond to immunotherapy or chemotherapy in the first place. So often as an oncologist, we're having to think of what do we use? And we will often try to give them the benefit of the doubt and still use other chemo and probably use other immunotherapy, but not sure that that's the right answer. And these are going to be the most challenging cases that we all see, because obviously they have had reasons why we thought we could potentially take them to surgery and then couldn't.
I think this conversation just goes back to the whole purpose of this particular section is the importance of an MDT. Because the more you know, the more you don't know, right? And so when you reach that point of there's only so much we know, we're at a point where we really don't know. That's when I think the benefit of having a multidisciplinary tumor board really shines, where you really get kind of informed input from different perspectives that really help you try to get to a reasonable option in a very complicated situation.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.